We are very excited to have everyone here today in person, and for those of us who are joining on Zoom, we'd like to start with one brief announcement. We received word yesterday from NACLS. We are formally fully accredited. We received a 5-year award, which is the most that you can receive as an initial program. I would like to extend a heartfelt thanks to faculty, to staff, and for those students who took a chance on UTHSC. It has paid off, and thank you.
Thank you all again for joining us today for Anatomic Pathology Friday. We have 2 of our second-year students presenting cases, surgical pathology cases that they were a part of during their clinical year. So first up, Elaine, Violet.
Good afternoon, everybody. My name is Elaine Violet, and today I'll be speaking on a case that I grossed with the West Tennessee Healthcare Group in Jackson, Tennessee with the Jackson-Madison County General Hospital. And the title of my presentation is From Hilum to Cortex, the Gross Examination and Diagnosis of Clear Cell Renal Cell Carcinoma. Before I begin, today's listeners will be able to, by the end of this presentation, interpret possible kidney neoplasms based on gross morphology, apply AAPA grossing guidelines for a radical nephrectomy specimen, list the key anatomic landmarks and margins relevant to gross examination of the kidney, differentiate between perinephric fat invasion and sinus fat invasion, critique a gross description for clarity, and recall the basic PT category definitions for renal cell carcinoma. And a brief outline of what I'll be covering today. I'll start first with the kidney, starting with the anatomy, followed by the microanatomy, followed by an overview of renal cell carcinoma, its clinical presentation, its etiology and risk factors, as well as its different microscopic appearances. Finally, I'll go into a case overview, starting with the patient presentation, as well as the AAPA grossing guidelines for a radical nephrectomy specimen. Then I'll move into the findings of the case, starting first with photographs of the specimen, followed by the gross description and photomicrographs from the microscopic slides. I'll wrap up with a diagnosis, starting first with the AJCC staging criteria, and then the final diagnosis and prognosis for my case's patient. First, the kidney is a very important pair of organs within the body. It is important for filtering blood, regulating minerals, and secreting key hormones, including erythropoietin, which stimulates the red blood cells in the marrow, renin, which is an important component of the blood pressure system, and calcitriol, which is a regulator of calcium and vitamin D metabolism. If you didn't have fully functional kidneys and didn't have access to dialysis, you would die within 4 to 6 days, so they're very important for the body. In this diagram, I have a picture of the kidneys as they sit within the body. You'll notice that the right kidney sits slightly lower than the left kidney, and this is due to its relationship with the liver. The kidneys sit roughly in the T12 to L3 vertebrae, next to the T3 to L3 vertebrae, and sit in the posterior aspect of the body. In this diagram, it shows the kidney in transverse section at the posterior aspect of the body. And towards the top of the screen, you can see the peritoneum, which typically wraps around the abdominal viscera of the body, of the abdominal cavity. And the viscera here are not shown. And then here is the kidney in transverse section, and it is anchored in place by the renal fascia, which is separated into 2 layers, an anterior renal fascia, often called Gerota's fascia, and in a posterior renal fascia, which is sometimes referred to as Zucker-Candles fascia. And Gerota's fascia is important to keep in mind as it's often referenced in operative reports, and it serves as an anatomic marker for the anterior surface of the kidney. Moving into the internal structure of the kidney, this diagram shows the kidney in cross-section, and the first item I'll point out is the fibrous capsule on the outside part of the kidney, and this capsule will peel easily away from a healthy kidney, but tends to stick to unhealthy kidneys that have cystic change or other disease processes. And you'll notice this in the gross room. Additionally, the kidney is divided into a cortex and medulla, which is easy to see in a normal kidney. The cortex is darkly colored because it is packed with glomeruli, and the medulla is organized into these pyramids, which end into a renal papillae. The hilum of the kidney is where the renal artery enters, the vein exits, and the ureter begins. And not shown in this diagram is the perinephric fat, which goes around the kidney and enters into the sinus of the kidney. And this is important because as well as wrapping around the vessels and the ureter and pelvis, the fibrous capsule that I mentioned earlier does not continue into the sinus cavity. So that is an area where tumors can infiltrate into the soft tissues of the body and is important for staging purposes. The flow of filtrate from the body starts with the renal cortex before flowing into the renal medulla, the papillae, the minor calyces, the major calyces, the pelvis, and finally the ureter and bladder. Each kidney has around 1 million nephrons, the functional unit of the kidney, and blood enters the glomerulus, this yarn ball-like structure here, where filtration begins and the flow continues down the proximal tubule, the loop of Henle, and then the distal tubule before collecting in the collecting duct. And as filtrate passes along this pathway, it continues to concentrate and become urine. In this slide, on the right-hand side, we can see an electron micrograph of the glomerulus and the capillaries that make up the glomerulus. And you can see they're very convoluted and wrapped up in like a ball-like structure. On the left-hand side, is the entire renal corpuscle in a 2D micrograph. On the outside, we can see the Bowman's capsule, and then further on, we can see the parietal layer of the white layer is Bowman's space, and the parietal layer is Bowman's capsule. And around the renal corpuscle are the tubules in cross-section, which I mentioned earlier, and they are important for taking the filtrate that runs through the glomerulus and further concentrating it. And zooming in still further to the glomerular structures, on the right-hand side, we have the capillaries looking out from the capillary into Bowman's space. And you can see all these holes or fenestrations. And these fenestrations allow plasma to pass through, but holds back cellular components such as red blood cells. Second, and not pictured on this slide, is the basement membrane, which these endothelial cells sit upon, made of a meshwork of type 4 collagen, which acts as a sieve to keep back large proteins and negatively charged proteins. Third, on the left-hand side, we have a podocyte and its processes wrapping around a capillary. And these processes are called pedicels, and they form little finger-like digits called filtration slits. And not seen in this image because they're too small. There's actually molecules between the filtration slits that act as a third meshwork-like layer that helps to filter the plasma even further and acts as a selective barrier for that plasma as it passes into the Bowman's capsule. And now, besides giving an overview of the kidney anatomy and microanatomy, the reason I would go into this level of detail is because the kidney is arguably the most functionally complex organ in the entire body, second only to the brain. For context, here's a brief overview of the subheadings within Robin's pathologic basis of disease for all the potential conditions within the kidney, starting with glomerular diseases as well as tubular and interstitial conditions. It moves on to cystic diseases and finally with neoplasms of the kidney. This shows just how many ways the kidney structure and function can fail. And this chart right here is taken from the AJCC cancer staging system. And it's a fully comprehensive list of all the malignant neoplasms of the kidney. And you can see that there are quite a few here, but for the purposes of my presentation, I will focus only on the most common renal cell carcinomas that are encountered in the gross room. And continuing through this presentation, I will be using renal cell carcinoma and RCC interchangeably to make it easier to talk about renal cell carcinoma. Next, the most common clinical presentation of RCC is the symptoms including hematuria, or blood in the urine, flank pain, and a palpable abdominal mass. Unfortunately, for the most cases, RCC is asymptomatic and not usually detected until it's far advanced. And another unfortunate aspect of RCC is its tendency to invade the renal vein into the inferior vena cava and extend all the way up to the right side of the heart. Additionally, RCC has a tendency to metastasize, and the common sites of metastasis include the lungs, the bones, the liver, the brain, the adrenal glands, lymph nodes, as well as uncommon sites such as the skin, the larynx, and the sinuses. Approximately 1.8% of all individuals in the United States will be diagnosed with some form of kidney cancer in their lifetime. The most common kidney cancer is RCC, and it accounts for 85% of renal cancers in adults. Its peak incidence is in the 6th to 7th decade of life, and it predominantly occurs in men over women. The risk factors for RCC include smoking, obesity, and hypertension, with smoking being the strongest modifiable risk factor and the easiest one to correct. Additionally, there are occupational exposures that can cause RCC, including exposure to cadmium, petroleum, and asbestos. Most renal cancer is sporadic. However, there are syndromes that are hereditarily linked, including von Hippel-Lindau syndrome, Birt-Hogg-Dube syndrome, as well as mutations with the MET gene. And all of these mutations influence the growth pathway of the renal tubules, which is where RCC arises from. Next, the spectrum of RCC subtypes. This chart displays their typical gross appearance, and starting at the top with clear cell renal cell carcinoma, its typical appearance is a golden yellow due to a high lipid content. It is also typically variegated and displays hemorrhage or necrosis. Next, papillary RCC is gray tan, friable, and hemorrhagic, and typically has a pseudocapsule around it, although that only happens in about a third of cases. Chromophobe RCC is a tan to light brown, homogeneous, and well-circumscribed carcinoma. And after that is collecting duct or medullary carcinoma, which is a firm gray-white infiltrative carcinoma, and it typically does not have a well-circumscribed boundary. At the bottom of this list, I have included oncocytoma, which is not an RCC subtype. It is a benign neoplasm, but it can be often confused with chromophobe RCC, and that's why I include it here. It is a dark tan to mahogany brown and central with a stellate scar, and like chromophobe, it is well circumscribed. And as I move forward, I'll be showing you gross photographs of these different types of RCC, starting with the collecting duct carcinoma. And in this photograph, we can see that the tumor exists right here, but it's hard to differentiate where the normal renal parenchyma ends and the cancer actually begins. And again, the collecting duct carcinoma is gray, white, and poorly circumscribed. Next, the chromophobe RCC is a pale tan to light brown color, usually lobulated and invasive. And in this picture, you can see that it is invading the sinus adipose. Next, that oncocytoma that I mentioned before is a benign neoplasm that can be confused with chromophobe RCC. And it is a dark tan to mahogany brown, a darker color. And in this picture, it's sitting within the central aspect of this kidney. Next, the papillary RCC is a tan to gray color, although in this picture, that is hard to differentiate because it's extensively hemorrhagic and necrotic. And you can see that it does have a pseudocapsule, which occurs in about a third of cases. And then finally, the most common RCC is clear cell RCC. And in this photograph, you can see that golden yellow color, which mimics the color of the surrounding adipose, except it's more of a gold or orangey tone. And it's got a variegated cut surface here and has possibly sarcomoid change. Now I'll be moving into an overview of my case presentation. First, the patient presented to her doctor with diarrhea, left-sided pain, and nighttime urinary incontinence. An abdominal ultrasound noted a 2.7 centimeter mass in her lower right kidney, which was solid and suspicious for RCC. No biopsy was performed, but a radical nephrectomy was performed, and the specimen was sent to the gross room for examination. Before I move into what I received, this is the grossing guidelines for a radical nephrectomy specimen from the AAPA. And these guidelines give an overview of how to approach the specimen and make it so that each specimen is treated with the same care every single time. And I want to point out here that the margins in a radical nephrectomy include the renal vein, the artery, the ureter, and the outer surface, especially after it's inked. And then findings for my case. First, the radical nephrectomy that I received was in this photograph, and I want to point out that this has a lot of perinephric fat, and facing the camera right here is Gerota's fascia. So this is the superior surface, or I'm sorry, anterior surface. And I'd also like to point out that this is a really great example of a radical nephrectomy specimen. So the surgeon did a good job of removing plenty of perinephric adipose. And this is what the specimen looked like at the hilum. The purple arrows point to the clips where the possible margins are. The green circles are other possible margins. And then this blue box here shows the upper pole of the kidney, which is peeking out of the fat. And this is likely because the surgeon had to dissect away the adrenal gland, and therefore there's no fat in that area. Finally, after inking the specimen and taking the ureter and vascular margins, this is what the hilum looked like. And I included green boxes to show those different vascular lumens. And zooming in, we can see peeking out here from the renal vein margin and giving a hint as to what is inside of the kidney is a renal thrombus of golden yellow tumor. And This is a picture of the specimen right after I bisected it. And before I finished the cut, you can see both halves of the kidney clearly, as well as the tumor in the lower pole. And zooming in a little bit, we can see the tumor takes up most of the lower pole here and is invading into the sinus adipose. And again, the sinus adipose is here, but it's gone away in this part of the picture. And zooming in a little bit further, it's hard to tell in this picture, but it is pushing up against the capsule. And after cutting through the kidney itself, on the backhand side of this particular section, it approached the inked surgical margin by 1 to 2 millimeters. And this is the gross description itself. I'm not going to read to you exactly what I wrote here because I did go over most of what was encountered. The AAPA has recommended sections, including the renal vein, artery, and ureter margins as the first block. And I will say for this particular case, the most important section that I took was the tumor to renal vein, and I'll show you why a little bit later. And then moving into the gross description, there's a few points that I want to point out. First, the tumor itself was 3.5 centimeters in greatest dimension. It extended past the renal vein margin, but wasn't adherent to the lumen, and it invaded the sinus adipose as well as the pericaval system, but did not involve the pelvis exactly. And I want to use this moment as a quick teaching point. I use the term invade for both the sinus adipose and the pericaval system. And in the start of my clinical rotation, I did a radical nephrectomy specimen, and I used those same words to describe a specimen that was invading both the sinus and the perinephric fat. And the final diagnosis on that case turned out to be oncocytoma, a benign neoplasm. And the pathologist gave me some valuable feedback that I'd like to share. When the relationship isn't certain, or there could be another potential diagnosis, such as in the case of an oncocytoma or a chromophobe, it's better to choose more neutral language. For example, instead of using the term invade, I could have used extend into, push into, or abut the surrounding fat. And that verbiage communicates exactly what I saw at the grossing bench without necessarily inferring what the pathologist would have seen on at the microscope. And just a reminder, this is what a oncocytoma, a benign neoplasm, looks like. And you can see here it is compressing the sinus fat and the perirenal fat, but it does not have the capacity to invade those, because it is benign. Whereas in this picture of the chromophobe RCC, this is an invasive neoplasm, and it is invading into the sinus fat. And next, I'm going to move into the microscopic findings of my case. First, here is an overview of what normal renal parenchyma looks like. You can see here there are 3 glomeruli, as well as very well pronounced tubules surrounding those glomeruli. And again, this is just a reference to what normal would look like. And here is a section from my case. And you can see first on the lower right-hand side is a vessel wall. And then everywhere else is a mass of purple cells. And there really isn't any renal architecture here. It's just a mess of purple. And this is clearly a mass of some sort. And there is a suggestion that possibly there could be some renal tubule architecture here, but it's not well organized and is not making up the kidney correctly. At higher magnification of that same slide, this is the characteristics of clear cell renal cell carcinoma. The tumor is composed of cells with clear cytoplasm and distinct cell borders arranged in nests and cords surrounded by a delicate network of vessels as here. The clear appearance comes from the high lipid and glycogen content that is dissolved during processing and what gives the tumor its golden yellow color. And then moving into some more slides from my case. So this shows the renal vein section margin that I took of the mass to renal vein. And you can see here, this is the mass here, and this is the wall of that vein. And you can see that the mass abuts the vein and even possibly invades into the wall here. At this magnification, it's hard to see. And that this is a more proximal aspect of the renal vein, and this is a more distal aspect of the renal vein. And again, you can see that there is mass within the lumen. However, it does not contact the renal vein here. And again, this is a more distal section here. And with this, together with the photos I took of the hilum, as well as the renal vein margin, the pathologist was able to call the renal vein margin clear. And wrapping up with the diagnosis for my case. First, the AJCC gives the RCC staging definitions as these in summary. And I'm not going to go over them, but this is what they are. And in the final report, the pathologist diagnosed clear cell renal cell carcinoma. The tumor was 3.5 centimeters in greatest dimension. There was invasion into the renal sinus fat and the renal vein. There was a renal vein thrombus. Gerotis fascia was present but not involved, and the pathologist called all the margins negative. No nodes were identified, and at the time of surgery, no metastasis was found. And from all that information, the PT stage was a T3A because the tumor invaded both the sinus fat and the renal vein. With that information, we can also come up with a prognostic stage group. When the T is a T3, no nodes were found, no metastasis was found, the prognostic staging is a stage 3. And overall, this is good news for the patient. The disease was localized, but unfortunately advanced because it did invade into the renal vein. There is a chance that there will be a recurrence or a metastasis in the future. And the 5-year survival for this patient is around 76%. Because of the advanced stage of this disease, the patient will likely have follow-up imaging of her lung, bones, and liver for metastasis. And unfortunately, that will be part of her health history. And with that, I'd like to end the presentation and thank you all for your attention, as well as a special thanks to Dr. Ashley Porter, Dr. Daniel Peterson, and the whole team at the West Tennessee Healthcare Group. Here's my references. Does anybody have any questions? Thank you.
Thank you, Elaine. Wonderful presentation. Okay, next up we have Lauren Wheelock in Alabama, and she will share her screen.
Okay, can everyone hear me, hopefully? We're good? Okay, perfect. So hi, everyone. My name's Lauren. I am a second-year PA student at the newly accredited University of Tennessee Health Science Center. And this is uterine carcinosarcoma, a classic case of a rare malignancy. So here's a brief outline of my presentation. I'll begin by reviewing relevant uterine anatomy and then follow that with the relevant uterine microanatomy. I'll then introduce the pathology that is uterine carcinosarcoma, and then I'll introduce our actual case, beginning with the clinical history of the patient, followed by gross photos, then histologic photos, and then we'll wrap up our presentation with the AJCC cancer staging system specific to uterine carcinoma, followed by the final diagnosis of our case. And then to finish out, we will compare our case to the relevant scientific literature for uterine carcinosarcoma. So here are some learning objectives. By the end of my presentation, I'd like all audience members to be able to identify the anatomic components of the uterus, recognize the layers of the endometrium, and describe the key differences between premenopausal and postmenopausal uterine wall layers, differentiate between the epithelial and mesodermal components of uterine carcinosarcoma, list common special stains used in the diagnosis of uterine carcinosarcoma, and finally, be able to compare and contrast the typical features of uterine carcinosarcoma found in scientific literature to our case study presented today. And with that, let's review relevant uterine anatomy. So, the uterus is a muscular organ that will typically weigh between 50 to 60 grams in healthy individuals that haven't recently given birth or undergone menopause. It typically measures 7.5 by 4.5 by 2.5 centimeters, although those measurements are subject to change based on anatomy. I think that uteri, are sort of inverted triangular shaped. So the base of our inverted triangle is what I'm highlighting here with my cursor, and that is called the uterine fundus. At either side of the uterine fundus, we have cornu that correspond to the attached fallopian tubes. So fallopian tubes are those tubular structures that are located on either side of our uterine fundus. We have a right and a left, and those communicate with the endocrine organs for the female reproductive tract, the ovaries. So ovaries are sort of oval-shaped endocrine organs on either side. Again, we have a left and a right. And those are responsible for egg production as well as production of estrogen and progesterone. Back to our uterus. So the upper 2/3 of our uterus are called the uterine body, also called the uterine corpus. And then the apex of our inverted triangle is formed by the uterine cervix, and that's this structure down here. The uterine cervix separates the uterus from the vagina. However, there is sort of a clear tunnel-like communication called the cervical os, which is represented as this sort of gap in this light purple structure, but I have a better picture coming. The center cavity of the uterus is formed by the endometrial cavity. The mucosal lining of the uterus, the endometrium, which is this dark red triangular structure in the photomicrograph on the right. I'm sorry, that's a depiction, never mind. That will undergo cyclical proliferation and regression if conception is not successful. And that'll happen under the influence of estrogen and progesterone, again, those ovarian hormones. That cycle begins at puberty and continues through menopause. So here is a very famous gross photo of a uterus. So again, if our uterus is an inverted triangle, the base of our inverted triangle is this rounded superior structure called the uterine fundus. On either side of that, we have our cornu that are attached to our fallopian tubes, again, a left and a right. And then those communicate with our ovaries. These are these sort of oval white tan structures on either side of the uterus. Back to our uterus, we have our uterine corpus, and then the apex of our inverted triangle is formed by our uterine cervix. In this picture, you can actually see the cervical os clearly. It's this sort of dark red slit-like structure. The external surface of the uterus is lined by peritoneum, also called serosa, and that's that shiny structure, the shiny covering present on the external surface. And then on either side, we also have perimetrial margins. Now, in this picture, we are looking at the posterior surface of the uterus. And I know that because I can see the ovaries clearly and entirely. And here is how I know that we were looking at the posterior surface of the uterus. So this is what the uterus looks like within the pelvic cavity. It's the organ directly posterior to the bladder. So in this picture, the bladder is this structure here. It's the anterior most organ in the pelvic cavity. So again, posterior to that is our uterus, and then posterior to our uterus is the rectum. So between the rectum and the uterus is a space called the pouch of Douglas, and that's important for things like metastasis or infection or fluid buildup. And then I mentioned that we knew that we were looking at the posterior surface of the uterus in that last picture because of the presence of the ovaries. And here's why. So again, if our bladder is the anterior-most structure, that would indicate that our fallopian tubes are anterior to our ovaries here. So let's talk histology. So, in women of reproductive age, the endometrium is composed of pseudostratified columnar ciliated epithelium that is influenced by estrogen and progesterone. The menstrual cycle is composed of 3 stages. I'm going to go through them very, very briefly. The first stage is menstruation, which is when the endometrium is shed. The second stage is the proliferation phase, which is when the endometrium proliferates and the endometrial glands elongate in preparation for ovulation. The third stage is the secretory phase, in which the endometrial glands produce a thick glycogen-rich secretion. Glycogen is an important source of nutrition for the fertilized ovum if fertilization were to occur. The second stage, is influenced by estrogen, and the third stage is influenced by progesterone. The endometrium itself is divided into 3 layers, so we'll go through these from deep to superficial. So the deepmost layer is the structure labeled B on the picture on the left, and that is the stratum basalis, and that's directly adjacent to our myometrium. The stratum basalis is the layer that undergoes the least amount of change during the menstrual cycle and is not shed during menstruation. Superficial to that, we have the stratum spongiosum, which includes stroma with a spongy appearance, hence the name stratum spongiosum, and that's what's labeled with an S in the picture on the left. Superficial to that, we have the stratum compactum, which is labeled C in the picture on the left, and that's composed of cells that exhibit a compact stromal appearance, hence the name stratum compactum. Now, the stratum spongiosum and the stratum compactum comprise the stratum functionalis, which is actually what is shed during menstruation. Again, deep to all of that is our myometrium, which is composed of smooth muscle cells arranged in ill-defined layers that are tightly packed together. Also within the myometrium is a network of arteries and veins supported by a collagenous supporting tissue. That is important for our pathology that I will dive into after this. After menopause, the production of estrogen and progesterone stops, which causes the entire female genital tract to undergo atrophy. So in the photomicrograph on the right, we have a slide from a postmenopausal uterus. So the endometrium is much thinner in comparison to the premenopausal slide on the left, and the glands, which are the structures labeled G, are fewer and far between and much thinner in comparison to the premenopausal slide on the left. And then also of note, the myometrium will also undergo atrophy after menopause, and it shrinks to approximately half of its size, again dependent on anatomy. So we've talked about all of the relevant anatomy and microanatomy. Let's talk about our actual pathology. Uterine carcinosarcomas, also called malignant mixed Müllerian tumors or abbreviated MMMT. I want to point out some of the literature did say mixed malignant Müllerian tumors, so the wording kind of depends on the author. But they're extremely aggressive tumors of the uterine corpus that contain both malignant epithelial and malignant mesodermal components. Both of those components originate from the same precursor cell. They account for about 2 to 4% of all uterine malignancies, so again, very rare, and for about half of all uterine sarcomas. Since uterine carcinosarcomas are so rare, their risk factors haven't been widely studied. However, the most common that I found across most literature that I read included things like prior pelvic irradiation, chronic estrogen exposure, and tamoxifen use. I do want to point out the definition of chronic estrogen exposure wasn't well defined. So whether that was hormone replacement therapy or topical estrogen use or just excess adipose tissue, it sort of wasn't clearly defined amongst most of the studies that I read. And then also of note, African American women are at increased risk of development. Most patients diagnosed with uterine carcinosarcoma are postmenopausal and range in age from 65 to 71 years old. The classic presentation of this malignancy includes things like abnormal or postmenopausal uterine bleeding, sensation of a pelvic mass, pelvic discomfort or pain, constipation, and urinary urgency. A uterine ultrasound can also reveal an enlarged uterus if the patient is suspicious of uterine carcinosarcoma. Treatment of this malignancy is primarily surgical. However, chemotherapy and radiation can be used as well, although there is no true protocol for that currently. The overall 5-year survival rate of uterine carcinosarcoma is between 10 to 50%. However, that rate will decrease to less than 10% if the malignancy is found to have extended outside of the uterus at time of diagnosis. Grossly, uterine carcinosarcomas typically form a polypoid mass that will originate from the uterine corpus. They typically have fleshy cut surfaces, commonly with necrosis and small amounts of hemorrhage, and they have a tendency to fill the entire uterine cavity and protrude from the os. So, in the picture on the left, we have the external surface of the uterus cut through the anterior surface. And again, if our uteri are inverted triangles, this would be the base of our inverted triangle corresponding with the uterine fundus, and our apex is formed by our uterine cervix, and protruding from that cervix is this gray tan sort of necrotic looking mass. On cut surface, we see that mass fills the entire uterine cavity and is continuous with the protrusion from the os. It has also sort of pushed away the remaining uninvolved myometrium. Histologically, uterine carcinosarcomas are biphasic tumors with both carcinomatous and sarcomatous elements. Of the carcinomatous elements, the most common are high-grade endometrioid or serous carcinomas. However, clear cell carcinomas can rarely occur. The carcinomatous elements have a high affinity for large vessels and lymphatic invasion, which would both be present in the myometrium. The sarcomatous elements are most commonly composed of spindle cell malignancies. However, about 50% of cases contain heterologous elements, the most common of which were rhabdomyosarcoma and chondrosarcoma. However, I did read one study that mentioned liposarcoma as well. So the carcinomatous component is most commonly composed of a serous carcinoma. And so what we'll see histologically is irregular glandular proliferation with pleomorphic nuclei, prominent nucleoli, and abundant mitotic figures. So in the picture on the left, we have very pleomorphic appearing nuclei with quite a few mitotic figures. Those are those darker stained purple structures. Conversely, the sarcomatous component, again, is most typically composed of a spindle cell malignancy. So in the picture on the left, we have really haphazardly organized spindle cells with no clear orientation as to which way they're supposed to be facing. And those will also have fairly pleomorphic nuclei as well. When doing my research for this case, I found this picture from Pathology Outlines to be so helpful. The center photo on the top row has a low power overview of an MMMT. And then on the left side, we have a higher power view of the carcinomatous component, which in this case is formed by serous carcinoma. And on the right side, we have a higher power view of the sarcomatous component, which in this case is formed by a spindle cell malignancy. And then the bottom row shows common special stains. So in regards to special stains for the carcinomatous component, it's typical to be positive for PAX8, EMA, and cytokeratin. So what is PAX8? PAX8 is one of 9 members of paired box gene transcription factors that regulate organogenesis. PAX genes are involved in CNS development, eye, kidney, and thyroid development, and the development of organs derived from the mesonephric, also called the Wolffian duct, or the Müllerian duct. Of note, most of the female genital tract is derived from Müllerian ducts, so it's no surprise that PAX8 would be expressed in gynecological malignancies. It's also expressed in epithelial neoplasms such as endometrial carcinoma. EMA is the epithelial membrane antigen. So again, no surprise that is expressed in the epithelial or the carcinomatous component. And cytokeratins are proteins of the cellular intermediate filaments. Cytokeratin markers will stain positive for the carcinoma component of carcinosarcoma and is used as a broad special stain panel to confirm epithelial origin. Serous and high-grade endometrioid carcinomas can also express positive p53, and rarely they can stain positive for ER and PR. In regards to special stains for the sarcomatous component, they will also stain positive for p53. p53 we mentioned quite a bit in pathology. That's the tumor suppressor gene, so mutations in p53 can lead to tumor formation. And then in regards to those heterologous elements, rhabdomyosarcoma can stain positive for desmin and myogenin, and chondrosarcoma can stain positive for S100, as can liposarcoma if found. So again, the bottom row of this picture shows positive p53 and p16. Those are things that we expect, but it also shows vimentin, which was not necessarily super common amongst the literature that I read. But vimentin is an intermediate filament protein present in mesenchymal cells, such as fibroblasts, that plays a crucial role in cell adhesion. It's a marker for epithelial mesenchymal transition, where epithelial cells lose their adhesion and acquire mesenchymal-like properties. So again, carcinosarcomas are biphasic tumors. Vimentin it should be no surprise that it might stain positive for that. So we've talked about quite literally everything but our case report. Let's talk about our case report. So unfortunately at this hospital, clinical history for pathology was fairly limited, but what I do know is that this patient was 70 years of age and postmenopausal with a chief complaint of postmenopausal bleeding. The things that I don't know are if she had any kind of prior pelvic irradiation or estrogen exposure, and I was unaware of her ethnicity. So across my bench, I got a total hysterectomy with attached bilateral fallopian tubes and ovaries. However, by the time I thought to take a picture of this case, I had already taken those structures off. And then separately, I had also received right and left pelvic lymph nodes. The uterus weighed 438 grams, so it was quite large and heavy, and it measured 12.7 centimeters from fundus to cervix, 6.2 centimeters from cornu to cornu, and 6.2 centimeters from anterior to posterior. On initial external examination, I noticed this disrupted area on the anterior serosal surface that measured 4.2 centimeters in greatest dimension and was probably consistent with previous cesarean, although clinical history was again limited, so I have no way of confirming that. And then she had a second disrupted area in the adventitial surface. It's sort of in line with the top of my forcep here. It's this darker stain or darker hole-like structure, and that measured 2.5 centimeters in greatest dimension. I pulled it apart just a little bit more and did notice that I could see a mass through it. So I was quite worried about it. Therefore, I differentially inked it red. Her cervix, which is this blue structure down here, was blue-green due to sentinel dye, and protruding from the os was more of that same polypoidy white material, similar to what I saw within this disrupted area. So I bisected the specimen, and what I saw was an 11.6 centimeter mass that was grossly adherent to the fundus and the uterine corpus and did fill the entire uterine cavity and was continuous with the protrusion from the cervical os. I do want to mention it had incredibly fleshy cut surfaces, but every time I cut it, more of this tumor sort of fell off on my blade. So I sliced fairly thick just to preserve specimen integrity. But I continued slicing, and what I found was that that tumor had invaded well beyond 50% of the myometrium. So on the right, we have the deepest point of myometrial invasion here, which is what I'm highlighting with my cursor. I did notice that it wasn't directly up against that serosa, but it was very close. So I called that less than 0.1 centimeters away from serosa, and really sampled that area heavily. And then I mentioned that I was quite worried about that disrupted area within the adventitial surface, and the picture on the left shows why. Before we dive into it, my ink did bleed, so this red ink up here is not actually the disruption. That was just, unfortunately, ink bleeding, but because the tumor was really coming off on my blade, I tried to wipe it the best I could, but it wasn't coming off very easily. But anyhow, this tumor is very close to that disrupted area, if not involving it. I wasn't sure if this area was fibrosis from, chronic irritation, or if it was actual tumor involvement, but it was very, very close. And then within this slice, we also have the lumen of a large vessel that I was concerned about possible mass involvement with. In regards to sampling, CAP mentions 1 section per 1 centimeter of maximal tumor dimension, or at least 4 blocks of tumor submitted, including sections that demonstrate the deepest point of myometrial invasion. Again, because I was quite worried about this disrupted area and possible further microscopic invasion on this slice, I blew that 4-block minimum way out of the water just to make sure that what I was seeing grossly corresponded to what my pathologist was going to see histologically. Speaking of which, let's talk about histology. So again, this is a uterine carcinosarcoma. So we have the sarcomatous element on the left that is composed of a spindle cell malignancy, and on the right we have the carcinomatous component. So again, those spindle cells are sort of haphazardly disorganized and they're very darkly stained purple. And then again, the right is the carcinomatous component, which in our case was serous carcinoma. And so what we see is irregular glandular proliferation that are again darkly stained. I unfortunately do not have higher power pictures of either of those components, so I went back to pathology outlines to get some of those for all of you. So on the left, we have serous carcinoma. We've seen this previously in this presentation. Again, we have pleomorphic nuclei with abundant mitotic figures, and then on the right, we have a much higher power view of the sarcomatous component, in which we can see haphazardly organized spindle cells in sort of a loose stroma. I mentioned that the literature notes the carcinomatous element has an affinity for large vessel invasion, and unfortunately, our case was no different. So the picture on the left shows the tumor invading into a large vessel. And then I also mentioned that I was concerned about the disrupted area identified in the adventitial surface. And the picture on the right shows the malignancy pushing up against that disrupted area, but it wasn't actually extending beyond that, which is great for the patient. We ran quite a few special stains, all of which we have talked about except for one. So ER and PR was run that came back negative, but we were positive for PAX8, cytokeratins 8 and 18, P53, P16, and then we were negative for napsin A. So napsin A was not present in most of the scientific literature that I read when preparing this presentation, but napsin A is a commonly used stain for ovarian clear cell carcinomas, so I would assume that was used to rule out any kind of ovarian primary. So let's talk about the AJCC cancer staging system for uterine carcinosarcoma before we dive into how the case was signed out. So both of these tables on the right side of the screen are directly from the AJCC cancer staging system for uterine carcinosarcoma. T1 is defined as tumor confined to the corpus uteri, including endocervical glandular involvement. T2 is tumor invading the stromal connective tissue of the cervix, but not extending beyond the uterus. T3 is tumor involving serosa, adnexa, vagina, or perimetrium. And T4 is tumor invading the bladder mucosa and or bowel mucosa. In our case specifically, we did have stromal connective tissue involvement of the cervix, but we did not extend beyond the uterus. And we did involve more than half of the myometrium. So her final T-score was a T2. And unfortunately, both right and left pelvic lymph nodes were positive with tumor metastasis greater than 2 millimeters in greatest diameter. So her final N-score was an N1A. Now, in the middle of both of these tables, there is the FIGO stage. So what is FIGO? FIGO is the International Federation of Gynecology and Obstetrics that was established in 2009, with the newest version being released in 2023. It parallels the AJCC cancer staging system, but it also reflects and defines prognosis as well as therapeutic approach, and it documents patient status and outcome. It's used in conjunction with the AJCC cancer staging system for gynecological malignancies, but it gives its own score. So this case was signed out as a mixed malignant Müllerian tumor with a high-grade serous carcinoma component. It did involve greater than half of the myometrium on the anterior aspect, as well as greater than half of the anterior lower uterine segment, and it involved the endocervix. We also had large vessel invasion as shown in one of those histology slides. So her final score was a PT2 N1A with a FIGO stage of 2. So I think it would be fun to compare this case to the literature that I used when researching for this presentation. So across almost all of the studies that I read, uterine carcinosarcoma affects postmenopausal women between the ages of 65 and 71. In our case, our patient was 70 years old and postmenopausal. The typical presenting symptoms of uterine carcinosarcoma are postmenopausal or abnormal uterine bleeding, and in our case, our patient's chief complaint was postmenopausal bleeding prior to surgery. The most common epithelial component found across almost all studies that I read was high-grade serous carcinoma, and large vessel invasion of the carcinomatous component was incredibly common, which was no different for our case. Our epithelial component was high-grade serous carcinoma, and we did have large vessel invasion. The most common mesodermal component in the scientific literature was a spindle cell malignancy, which will ring true for our case as well. We also had a spindle cell malignancy as our sarcomatous component. The only way that we really differ from the literature is in risk factors, and that's really just from lack of clinical history. So most of the risk factors for the development of uterine carcinosarcoma included prior pelvic irradiation and chronic estrogen exposure, and African American women were at an increased risk of development of uterine carcinosarcoma. Again, in our case, I don't know if she had any kind of prior pelvic irradiation or used estrogen, and I'm unaware of her race. Before we end this presentation, I'd like to give a huge thank you to Dr. Hilliard at Vivid Pathology for signing out the case and for providing the histology photos, to Dr. Clary at the Cunningham Group for answering questions regarding histology on a case she did not sign out, and to Dr. McKenzie at Community Pathology Laboratories for guidance and direction throughout my rotation there. Here are my sources. Are there any questions?
No questions. Thank you so much, Lauren. Wonderful presentation. Thank you everyone again for joining us today. I'd like to let you know that our final presentation on forensics will be Friday, November 21st. And then for the second years, their last poster session will be Friday, December 5th. So